Good morning, everybody. My name is Howard Burns. I'm the editor of NJBIZ, and welcome to our monthly panel session here at the Imperia. This month, we're talking about healthcare technologies, and we have a very, very exciting panel today, and our moderator will introduce our panel. Our moderator is Cathy Bennett. Cathy was named president and CEO of the New Jersey Hospital Association in November. It's a nonprofit trade association representing the state's hospitals, health systems, and other healthcare providers with leadership on quality and patient safety, education and advocacy in Trenton and Washington, D.C. As CEO, Cathy oversees NJHA, the Health Research and Educational Trust of New Jersey, a not-for-profit affiliate that promotes continuing education, patient safety, quality improvement, and research. She also manages the for-profit Healthcare Business Solutions, which provides group purchasing and other business solutions for healthcare providers. Cathy began her career in the private sector with 20 years of experience as an executive providing consulting, strategy, and management services to federal and state health and human services agencies. She joined the New Jersey State Department of Health in 2010 as Director of Policy and Strategic Planning and Chief Information Officer. 5 years later, she became New Jersey's 20th Health Commissioner and served in that role until becoming CEO of NJHA. Ladies and gentlemen, please welcome Cathy Bennett.
Well, good morning, everybody, and I'm so glad to see a packed room because I know it's all about the panelists we have here today. What I'd like to do is just take a quick moment to have each one introduce themselves. And what I'd like to do is start immediately to my right with Don Parker from Carrier.
Good morning. Do you want us to say anything? All right. So I have to do a quick audience participation before I start. How many of you have been to see a doctor this year? Good, good. How about a dentist? Good. How about a psychiatrist? How many need to see a psychiatrist? All right, good, good. So I get a little flavor of what the audience is going to look like and what you're going to ask me. But I've applied technology in the world of behavioral health over the last 5 years. I want you to think back, because most of you probably aren't old enough to remember One Flew Over the Cuckoo's Nest. That was the last major application of technology in our business. And you saw it live. There's a searing, no pun intended, memory of that event where McMaster is getting ECT and he's being held down by 4 individuals and his hair lights on fire. That's the picture that has been left in people's minds about technology and behavioral health. So with that as a backdrop, I guess we'll have a little bit extra time for me to talk about the kinds of technology that we're applying. Lastly, I want to say that there's an incredible need. How many of you have had a significant conversation in your life that changed your life around, that helped you in education and marriage and friendship and work? How many, please raise your hand? So just about everybody in this room, you're all successful. You probably have many of those discussions. How many of you had it on this? I've had one trepid individual in crowds that I've asked over the last year. And so this tool enables us to do an awesome amount of work that we were never able to accomplish before. And it frankly has spread our thinking, our communications, our products throughout the world. On the other hand, it subtracts 65% of the value of communication because you don't get body language, you barely get tone, you don't get proximity, you don't get eye contact. 65%. So today I've been asked a lot about why the bullish market in behavioral health. The bullish market tracks back to this. So think about this almost as adding GMO into your verbal chain. Yeah, so what happens when you introduce GMO into your body? We don't know. We're studying it. But we're doing it. We never studied the impact of this when we changed our patterns of communication. And today, over 50% of communication takes place on a cell phone. And I can't do business without it. I've got to have it. I check it. I'm programmed to check it every 15 minutes. So what happens to you, though, when you take away the meaningful components, the things that feed your soul from your communication? And where do those communications take place? Where do those profound conversations take place? So I'll talk a little bit later as we come back about some of the things that we're doing at Carrier Clinic to change that.
So, here we are, feeding your soul. We're going to start off with, it's Don Parker, CEO of Carrier, in case anybody missed it. We're going to move on down the line, ask everybody else really quickly if you could introduce yourselves, and then we're going to get the conversation rolling.
I'm John Novak. I'm the Senior Director of Architecture and Government Technologies for the New Jersey Innovation Institute. New Jersey Innovation Institute is part of the New Jersey Institute of Technology. We are a healthcare organization based on value-based care and trying to advance healthcare from fee-for-service to the value-based programs, as well as we run the New Jersey Health Information Network for the State Department of Health, which actually was started under Cathy's tenure as the commissioner, and we're very glad to be moving that out into a production environment now.
And good morning, everybody. My name is Gillie McCreath. I'm a principal with Mazars USA, and we're a tax audit advisory firm just outside of the Big Four, about number 19. So just want to make sure everybody was awake on that. I've been in healthcare for over 25 years, and I've had the fortunate pleasure of working on the provider side, the payer side, the technology side, as well as consulting. I've worked with hundreds of hospitals around the country, as well as some internationally as well. And today I'll focus a lot around transparency, data, as well as what are some of the other tools and applications that we might be able to move the pendulum forward as we amidst this challenging environment today. Just a quick question before Cathy gets started. So how many people wear an iWatch or a Fitbit, right? So we just were having a little conversation. I forgot to charge my phone this morning or last night, and now I'm stuck here. So when we talk about capabilities and applications, we still have some additional challenges that we still have to plug in. How many people receive calls all the time on their cell phones? Again, when we talk about communication and care managers reaching out, we have to offset the challenges of getting bombarded continually on our cell phones. So we'll have to find a good balance of that moving forward around communication and applications.
Good morning, everyone. Good morning, other panelists. I'm Bryan McAlister. I'm the CEO of the Full Recovery Wellness Center. I'm also the gentleman who left those books out for you. I highly recommend them. Very interesting reading. I'm here because technology has been used in so many other formats, and I was glad to hear Don so enthusiastically start off because I'm involved in the treatment industry. Anybody have anybody that they know that's ever had a drug or alcohol issue? I don't think there's anybody. If you look at the national statistics right now, it's an epidemic, and 1 in 5 people qualify as having an addiction problem in America today. Drug overdose kills more people than automobile and gun violence combined accidents right now in America. So it is truly an epidemic. I got involved in this because, number one, my clean and sober date is August 2nd, 1990. So I've been sober 28 years, which is not the norm. And when my sister died of a heroin overdose several years ago, my partners and I opened up the Full Recovery Wellness Center to deal with this. When I got involved with this, I discovered very quickly that treatment modalities haven't changed all that much since I wound up in a treatment center back in 1990. So being from private enterprise, being from a corporate environment, we decided to take technology into this field, and we've developed the first virtual recovery system that's right now patented in America. And it really puts recovery in the palm of your hand 24 hours a day, 7 days a week for pennies a day. It doesn't take the place of treatment. You certainly, if you need a detox or you need other things like that, you need medical treatment. This is another tool in the suite, and I'll be happy to talk about that. But thank you for inviting me here today. And technology's finally reached the treatment industry.
Hi, everyone. Sandra Powell-Elliott. I'm the Vice President for Life Sciences and Innovation at Hackensack Meridian Health, and we're very happy to have Don Parker and the Carrier Clinic who have joined us. And obviously, we're kind of bookending it here a little bit because somebody's got to kind of manage his enthusiasm down there a little bit. Anyway, my role within Hackensack Meridian Health is really to begin to leverage innovation and how that ties with technology is a multitude of ways. But how do we leverage technology, both internal and external technology within the organization, to bring new business models, new ways that we can deliver care and services to the populations? both at a kind of what I'll call a physical level, maybe a mental level as well from a behavioral health perspective, but also from a life sciences at a cellular level. So we'll talk a little bit about that and how that actually ties to more purposeful innovation and the purpose of some of the technology that we're looking at embedding within our own organizations within the next coming years and months.
Thanks so much. So as you see, we've got a tremendous panel here, and we're covering really what I'm going to say is sort of the gamut. We're beginning with sort of the hows. How are we going to make technology interact with the healthcare system? And we're going to also get to the why. Why are we doing it? And ultimately, it's about not just who is the patient today, but those whole circles of supports around our patients so that we can have better outcomes. I mean, that's why we do what we do. So I kind of want to start with the big how question, and what are some of the things that we're doing within this evolving system of health information technology and mobile apps and devices. So, I think I would like to do is just turn it over to John for a little bit. And can you talk a little bit about what we're seeing from, the evolution of health information exchange and, what are some of the needed keys in order to make sure we're delivering right information, right time, right place?
Sure, absolutely. So one of the things we've seen is back when the whole meaningful use movement and moving from paper to electronic health records, New Jersey had 5 health information exchanges in it. Some of them have gone away, so we actually went down to about 5 active ones. Today we have about 10 health organizations that are in exchanges. So we see this ebbing and tide of organizations, and it's not just within New Jersey. We're now seeing Geisinger Health and Key High from Pennsylvania coming in, HSX, which is the greater Philly area, and as well as across the Hudson. It's not just a New Jersey issue. People seek care in and out of the state, and we have to be able to make sure that we cover them. One of the big pieces, if you're going to be giving health care to someone anywhere in the state, and they see multiple places. You have people that go down the shore during the summer, or people from Philadelphia come into Atlantic City. You have to be able to identify them. And that's one of the biggest challenges we've seen is how do you uniquely identify a person? John Novak, not a very common name, but there's at least 5 of us in the state of New Jersey, all around the same age. So how do you identify which one of us when we're seeking care? Because when you're talking anything, whether it's just traditional medical care or behavioral health or substance abuse, how do you uniquely identify that person to make sure that you're saying the right information and that you're sharing the appropriate information? So you need to be able to identify that person, and it's a very big challenge in New Jersey. We have organizations that won't collect social security numbers. We have public health registries that require personal information, which really, what does that mean? So you don't get date of birth for some of the state health registries, or you don't necessarily get the sex. So it's really hard to do patient matching. And if you're trying to move someone across a continuum of care, you really need to identify a person. So that's one of the biggest challenges. And actually, New Jersey is one of the few states that really has implemented a statewide master person index to try to uniquely identify people across healthcare. To this point, we've identified uniquely about half the population, about 4.5 million. So that's one key, is being able to identify people across the organizations. The other challenge is, as I mentioned, we have 10 health information exchanges, but they're all pockets. They're all silos. They don't necessarily communicate, whether it's a large system or an HI health information exchange organization. They don't talk with themselves. We're fortunate that we're starting to now be able to get them to connect and start to share data, but that's a big gap. If you go see, if you're in Hackensack Meridian, and then you go to one of the Robert Wood Johnson hospitals, they don't share the information today. We're starting to slowly move that.
We're competitors, but just kidding.
There is definitely that issue.
I'm just teasing. Actually, it is a major issue.
But you do need that, and we're starting to get to the point that they're now willing to do it. Part of it is because of the value-based care, and we know people are going to go from one organization to another, but how do you share that data and make sure it's the appropriate data at the appropriate time? And then when you talk about the providers, New Jersey is also very unique, is that we have one of the largest populations of 1 to 2 provider practices in the nation. And it really is cost prohibitive for some of these provider practices to be able to share that information with the health information exchange or with another provider, just because when they go to talk to their EMR vendor, there's a cost. When they talk to their health information exchange, there's a cost. When they talk to a local hospital, there's a cost. We really need to break down those barriers and make it so that it truly is interoperable. So if someone is seeking care whether it's inpatient or outpatient, then you look at behavioral health and long-term care, they were really left out of all the federal funding around meaningful use. So there's a huge gap where you still have long-term care practices and behavioral health institutions that are still on paper. You know, last time I looked at my calendar and my iPhone, my iWatch, which is dead, by the way, it was, you know, we're in 2018. Why are we still using paper? You know, I can go to any ATM and get my money. I can go do a Google search and suddenly Amazon's telling me, hey, there's a better price. Why can't I move my healthcare data?
Yeah, and one of the things that, just to kind of piggyback on that, I think what is critical, you know, it's just mind-boggling to think that we, at a basic level, can't share that level of information. Because as you mentioned, it's about trying to improve care, and there's a consistency of care. I mean, it's many of us go on Facebook and we log into multiple sites, and do you want to log in via Facebook? Yes. I mean, we do it because it's easy, kind of thing. And there's a consistency that, yeah, we don't want to log into our health information records via Facebook, you know, Cambridge Analytica. But, you know, there is a certain level of sophistication that should be consistent across the healthcare industry that we just haven't achieved yet. And unfortunately, we should get there. It's the Amazon level of core functionality. For some reason, we just haven't gotten there.
And that's twofold, too, because, right, the patient might be willing to share their information, but the hospitals themselves are the barriers to that. So some folks talk about, hey, maybe one day when we have the Epics and the Cerners of the world, maybe there'll be some more consolidation and maybe one HIE. But to your point around EMPI, I mean, 9% of patient misidentifications lead to ultimate death or permanent injury. 35% of denied claims are all around patient misidentification. So you just figure that along the provider value chain. I mean, it's not only affecting the clinical aspects, it's affecting the revenue cycle as well.
You know, in our industry, we have just the opposite problem because people don't want to be known. There's the anonymity feature of our product is so important because if you get we have a big first responder program, for example, and there's law enforcement and they carry a weapon, and there's different standards that society holds people to. So by getting involved with us, we take no information. Our whole deal is to get the information to the client, and we collect nothing, as minimal as humanly possible. Everything they give us is encrypted, and it stays with them. That means that we will have granular information, aggregate information to improve our product, but we will never know exactly who's got what. And this opens the opportunity for people to reach out earlier in the process. You've all heard the hitting bottom. They say you have to hit bottom before you go for treatment. Our goal with this is to get people off the elevator a few floors higher so they don't have to hit bottom. And if they do, then there's other people that are more appropriate to deal with that.
You know, we're looking at techniques, and we're going to talk a lot about that today, but we probably don't have enough time to talk about the business model that we deliver from. And if you think about whether that business model accommodates technology in a way that would make it great for patients. So if you think about anonymity, one of the worst places to send a patient who has a substance abuse problem is the emergency room. What's more crowded in a hospital than an emergency room? Where is your soul bared more than in an emergency room? So I'm actually pleased that we are on the pathway to complete a merger with Meridian Hackensack, and we're going to be partnering together to do behavioral health urgent care centers. At times when patients can use them and need them, and in a model that allows us to what I call jump the curve. We don't have to spend all of our time trying to reform the existing system. We begin to create a new avenue to deliver care that has the ability to aggregate the technologies in a digestible format. And that's a very different way than taking technology and putting it into an existing business model. Think about it. One flew over the cuckoo's nest 75 years ago. I still have people cringe when I talk about doing electroconvulsive therapy. It's an incredibly safe and effective tool. In fact, one of the most effective tools in psychiatry today. We do over 5,000 procedures per year at Carrier Clinic. I still am talking to patients in a very, very aggressive way that ECT is probably the best way for them to get their care. It's drug-free, it's electricity, it's safe, it's under anesthesia, all of those things. I'm fighting something that a picture created 35 years ago. So it really does require us to think on all of our cases, the business model from which we're delivering the technology.
So I want to swing back for a minute to a comment that Gillie made, where he said, "Hey, you know what? We've got Epic, we've got Cerner out there. It'd be great if we just get to one HIE." As we think about this, and John, you referenced it. It really, the use of EHRs, they all came out of really the the American Recovery and Reinvestment Act, ARRA, from the time that we had our Great Recession in the late 2007, 8, 9 era. And all of a sudden, lots of money is put on the street, and we've got really two behemoths. So from your perspective, and then maybe, Sandra, you want to circle in with it, do you think that in some way, some of the disconnect we have between medical devices, apps, EHRs, and amongst providers is actually driven by two of the greatest unregulated players in healthcare today, being Epic and Cerner?
Go ahead. No, well, it definitely absolutely is. Not that it's their business model. They're trying to make their way, their moves, but it goes back to the competition, the individual healthcare organizations. They might all be running Cerner or Epic. They probably account for 60% of the market in New Jersey, but they're all individual organizations, and it is that sharing. So while Epic has done a lot with their Care Everywhere platform, where you literally can share a medical record across any Epic provider, the hospitals don't want to do it. So we can't necessarily just blame the vendors. I think there is some culpability on the vendors from what I was mentioning before on that interoperability and be able to exchange information from the small practices. But I still think you do have that hospital healthcare system, that there are things out there. There are some national programs, Commonwealth, Care Equality, that are built around sharing the data and moving that needle forward. But there is a reluctance to share that data. Part of it is because you can't identify the person, part of it is that competitive advantage, and part of it is, well, I don't want them to see what's in my medical record. What if I have a mistake and I don't want to share it? They say, I believe, about 20% of medical records overall have some sort of error in them, whether it's identity or some misdiagnosis or miscoding. People don't want to share that. So there's stigmas around that. So it is a problem with the vendors, where definitely the vendors could make it much easier, especially for the smaller providers. But I think there is also that competitive advantage with the healthcare system and hospitals that are also blocking it.
Yeah, I would say, and I may be an anomaly here, so I take full responsibility for the editorial comment I'm about to make here. One is, I do think that there is some level of the Cerners and the Epics of the world that don't necessarily always make it easy to share information. So having said that, I do want to echo that I think that the competition between organizations does create a barrier, but I think it's also an artificial barrier. I think it is one that is born from history and isn't necessarily one of the areas I was about to head earlier. Was that if we had a common, consistent approach to sharing information, then it forces us as an industry and as an entity to begin to compete at a very different level. I have to compete on my ability to provide a care or service at a higher quality, at a better value, at an easier way for patients or providers to participate in my network. So it puts a tremendous amount of pressure on an organization. And I'm not saying that's a bad thing. I'm saying that's a good thing, quite frankly. And that's why the Amazons of the world do extremely well, because they figured out that if you leverage technology to automate as much as possible, those things that can be automated and should be automated, if I can digitize something, it should be automated. And minimize the amount of work that can be done, that needs to be done by people when it can be done by machines. It allows more for the ability of people to do those things that really require people, that person-to-person interaction, that creativity of trying to figure out what is that new product or service or offering, that innovation that we need to bring in that truly will differentiate us, that new way that we can take care of patients in a very different way in the operating room, for example. That's what you want, the people. That's the benefit of what people can bring to the table. where technology can't. And I think that that's where we as an industry have to get to. And, you know, I agree that I think we haven't done a good job in saying, you know what, let's share information and begin to understand how we can all do a better job at competing in a very different way versus just, I don't want you to get my information because I want to keep that patient. I need to figure out how to keep that patient in a very different way.
So banks, Cathy, I just want to add something to that. So banks have figured out how to do this. What's
Yep.
what's one of the more sacred things for you is how much is in your checking account or your savings account. You don't want anybody else to know
Right.
about that. So you keep it close to vest.
Yep.
But we figured out, and by the way, I think the evolution of systems now in healthcare are indications of what happened in banking. Banking used to be hometown business in every town, separate bank. We would not have been able to share the kind of information we share and give you access to in banking if we were all individual banks. And so the consolidation of healthcare now allows us to act like a PNC or TD or other organizations with large capability to have information within, and then interoperability or operability, I should say, among all the other players that are in the system.
Okay, so I was going to kind of circle back for a second though, because Sandra, you're actually talking about how we're using technology to drive efficiencies, and we're seeing what we're doing differently. Whether it's an ICU converting into an e-ICU,
Yep.
whether or not it's changing your interactions as somebody walks through the doors of an ED. So you have both your ED and your inpatient experience. And there's a lot that's going on with the data that you're seeing from a clinical perspective. But I wanted to ask Gillie, what are you seeing when you take a look at, say, clinical and financial data coming together? Is there something new that's starting to evolve, and are we starting to get new views into consumer behavior or provider behavior?
Well, one aspect of that, Cathy, is there's a reason why we're not just calling the whole movement of value-based care and population health triple aim. We're calling it quadruple aim, right? Because of physician burnout and nursing burnout. So the data fatigue, per se, is certainly out there. And we talk about data analytics, artificial intelligence. We have a long way to go around that. But I want to talk a little bit more, too, about what's happening today. Vima over at CMS has been on a tear recently. She just said, hey, no more fax machines in the physician practice offices. Wow, that should have happened 20 years ago, right? So what a revelation. But the other element to that is about transparency and cost transparency and price transparency. So we were actually here about 2 months ago with the NJBIZ, along with the CEOs of several health systems, and they talked about the interoperability challenges, but also about transparency and how some of the hospitals in New Jersey are starting to put their price on the website so patients can access more information. But there's really two buckets of transparency, right? Price around what the hospitals are charging and cost. What is it going to actually cost me as a consumer out of pocket? So we have certainly a long way to go relative to transparency, because how are we going to actually estimate or pre-adjudicate a claim around the whole continuum of care? If I get a hip surgery, what is it really going to cost me throughout the 6 months of rehab? I mean, that's what consumers want today. In Africa, they are pre-adjudicating claims. They're paying with an ATM card, money's coming out of their bank account, the full cost of service is being ultimately paid for up front. Now, that's a third world country, a lot less regulations, but they are doing it. Why can't we pre-adjudicate a claim? And Donald, to your point around banks, we should have our ATM card, our HSA card. We should be able to go to the hospital and say, swipe it. Here's what leading practice shows me. Here's the care protocols that are going to happen. You've had thousands of patients before me with the same kind of condition. You know what's going to happen to me at the end. Now, of course, there's going to be outliers, but I challenge the health systems in New Jersey as well as the country to really formulate a plan around transparency. And we certainly have some more tools that are maturing to help us along that spectrum.
So I'm going to put this question to our providers. It's going to be Don, John, and then Sandra. One of the things that you mentioned, Gillie, is that with the use of IT, we've got one, the transparency on the cost side. We know a big driver on cost is staffing, and you've referenced the use of health IT has led to different ways and different types of models. So we know that there are things like telehealth, there's telepsych, there's different things you're doing, for example, with an e-ICU. So could we start maybe, Don, with you and talk about maybe the role and maybe for telepsych in particular, how's that evolved over the past Gosh, 31 years?
Actually, I was just about to say 31 years ago, I was working for Atlanticare, and we had a shortage of psychiatrists, and we had the first telemedicine application in New Jersey at the time, and it solved problems for us. Telepsychiatry is a requirement because we have a shortage of 10,000 psychiatrists in today's economy. And there's no way that we can catch up. 892 graduates from residency programs on an annual basis. Math that doesn't work. 62% of all psychiatrists are over 60 years old. Think about that. And at this point, we need to extend careers. We also have more patients to see, and we need to see them in more convenient business models, like a behavioral health urgent care center. So that what we're working on now at Carrier is a smash up of technologies, so that we're looking at using facial recognition software in the same way that you watch TV news. You watch the pundits up top explaining what's going on down below in the ticker tape. And you have split attention and the capability to see both of those things simultaneously and process those. So what we're working on now is a product. We're using a Department of Defense company who's perfected this area of technology that can match up your facial expressions that are half a second long, that can't be seen by the naked eye, and then are correlated with disease states. The Department of Defense is using them for rule in and rule out for PTSD. You understand what the stakes are on that, either a suicide if you got it wrong, possibly, or a lifetime of support if you got it wrong for somebody who probably doesn't deserve it in those circumstances. So the correlation is significant and strong, and allows us to take a product that would be seen as inferior experience and take it to a superior level, because it gives additional diagnostic capability to the practitioners.
I'd like to comment on that also. What we're doing with our new product, the virtual recovery system, really takes that to the next level, because it has access 24 hours a day, 365 days a year, where you have interaction with recovery. If you know anybody in recovery, everybody will tell you the same thing. When I'm with my counselor, when I'm with my psychiatrist, when I'm in a 12-step meeting, I'm okay. But when I leave, I'm on my own, and that's when people relapse. Now you have access to interactive access to 24-hour day, somebody like myself who can tell you exactly what's going on and give you actionable solutions. You can type in any word, just like Google, and say, fear, anxiety, career, family, and instantly get several different videos and several different ways of interrupting that negative thinking pattern. It's funny because most of our early adopters are other treatment centers, because when the treatment, just strictly from a financial standpoint, as you mentioned, it costs a lot of money to get somebody in the treatment center. The cost of acquisition per client is about $5,000 a person. So when that person leaves, and there's about an 80% failure rate, when somebody leaves a treatment center, and there's only a 17% reacquiring rate when they come back. So if they leave and they relapse, they're going someplace else. So this allows the center or the hospital or the physician or the psychiatrist to stay tethered to their client, because there's a back end on this. It lets you know if they're using what features of the product they're using, how often they're using it. So instead of just having an alumni coordinator when somebody leaves a treatment center and randomly calls this person, with a shotgun approach and say, hey, how you doing? Are you still staying sober? And of course, being an addict and alcoholic myself, I can tell you, of course I'm staying sober. That's always the answer. The deal is this: you'll have an idea from our product whether they're participating, what they're using, what features, and if they're in danger, you can get them back. And in addition, insurance companies are requiring metrics. I'm from private enterprise. I demand metrics. I want measurable results for everything I do. And the industry I'm in, I found, was sorely lacking in this. So the idea is to capture these metrics to give the providers a better way of servicing their customers and give them an opportunity to ensure long-term success.
Okay, Sandra, one of the things that you've, talked a little bit about in the past is, it's changing how you actually run operations. Could you give us a little bit of a picture on maybe like your EICU and what it means from a staffing perspective, or how it allows you to keep or retain subject matter expertise that you might otherwise lose?
Yeah, one of the things that we're finding, as more and more moves to an outpatient arena, obviously those patients who are in hospitals are much more acute. They're extremely sick. And one of the things that results is your critical care population kind of explodes. And so it requires you to have a very large staff of extremely skilled individuals, skills that come over time for the most part. And what happens is, for us, our EICU effort is really to drive a couple of different things. One is not only on the support side of the nursing staff, but also on the physician staff too, and it goes towards burnout as well, is the ability to bring and kind of create a command center for some, is probably an easy way to kind of begin to think about it, where we've got a lot of data feeds coming in so we can actually begin to monitor multiple patients, and physicians and expertise for very critical patients can be disseminated not only in one location but in multiple locations. And what that does is it enables us, particularly for nursing staff or physicians who are potentially extremely skilled but can't go to multiple locations on the physician side, but on the nursing side maybe are getting close to retirement and can't necessarily, are looking to retire because they just don't want the physical strain of the job, and they've done their 35 years. It enables us to be able to retain that individual and that skill set, while at the same time beginning to be that backup of some of the newer, younger nursing staff that are critical care staff individuals, but may not have seen the same level of had the same level of experience yet, because they just haven't seen the same number of situations. So it enables us to extend that knowledge base for a much longer period of time, and not only in one location but multiple locations. So it's enabling us to extend our staffing model and create a new staffing model for the network as well.
So that's one of the things I think we're hearing as a theme, is that you see technology as a workforce extender, whether it's telepsych, whether it's how we use and provide data so that the skilled staff that's available can look at the feeds and start making some decisions rather than themselves running from room to room, so they can actually look at a greater population. And that all comes down to, I think, this question of, and John, you kind of raised it, looking at the metrics, looking at what you're seeing from an outcome, looking as something proceeds. So Don, you guys have been working on something called the Compassionate Care Index. Do you want to talk a little bit about that?
Sure. So we have a significant number of high-tech initiatives at Carrier Clinic, and it's not necessarily what you want when you're recovering from a psychiatric episode. And so we felt it was incumbent upon us to learn more about the science of compassion so that we could be really a high-tech, high-touch operation. We wanted to hear it from our patients. And so almost a year ago, we started work as a team of about 200 people at Carrier Clinic through a internal process to develop what we found at that point to be key drivers in a compassionate experience. What's coming from the staff? I started reaching out to hospitals to say, are you guys measuring compassion? You use it in your mission, vision, and values. I hit 60 hospitals randomly out of the AHA book, and I found 0. Nobody was measuring it. We kind of assume that our staff are compassionate because they're in this business. And so it allowed us to also reach out to all of the customer experience measurement companies, from Press Ganey to Jackson to PRC. None of those companies were measuring compassion either. So we developed our own index. I finally got the folks at Press Ganey convinced to include it on our customer satisfaction survey, and then began to use that information for 4 different things. The first was to identify what are the key drivers. Anybody guess what the key driver is? The number one key driver, well, we don't have a lot of time, so I'll tell you, is eye contact. Think back to my opening statement about the use of a phone. There's no eye contact in phone. You can Skype. It's not the same. It's disintermediated by this. So beyond eye contact, we began to see characteristics that we could load into a employee selection format. So that we grade our staff based on our new staff, based on their ability to be compassionate. We train in our orientation skills of compassion. We have a reward system called iCare in the organization that recognizes and rewards acts of compassion on a daily basis. So we don't wait until it's something big. Every day you can submit, and then there's a random selection of individuals for a prize on that on a monthly basis. And then finally, we have a relationship with a company in New York called the Schwartz Center. May the Schwartz be with you, for those of you who remember Spaceballs. And that's the only reason I went to them. No, they are actually exceptional at compassion fatigue, helping us prevent it. So we're processing moments to take away compassion. So all those things together allow you to match up the technology with a superior compassionate experience.
So, that's kind of interesting, and I know that metrics, and Gillie's looking to jump in, are also something that drive behavior. So do you want to talk a little bit about
Yeah, and I also have a follow-up question for Donald there, but I'll take that follow-up question real quick. I mean, it's interesting around telemedicine because we often hear about strategies, and I work with a lot of health systems who are formulating their telemed strategy to encompass behavioral health and psychiatry, and you touched upon the eye contact, and American Well has a deal with Samsung so that they have a 50-inch screen within your room, or they provide some kind of contact around the television, and the eye contact is so visual, right? It's a 4K TV, so it feels like you're actually there. But I'm curious to find out your thoughts around telemedicine, because when you again have that interaction, it should add to more of a volume, per se, for compassion care.
I think it's going to add substantial quality to the decision-making process that a doctor goes through. And a doctor does, for instance, we spend a lot of time looking at your pupil dilation in psychiatry. It gives us a whole variety of insights into you, whether you're taking a medication or not. And doctors, by the way, love when we can make your pupil this big. So, especially the older doctors. It allows us to look differently at a screen. So having a large screen is a great benefit to us. I'd also suggest that being able to see half a second micro-element facial expressions, which are imperceptible to the human eye, changes the whole dynamics of a telepsychiatry episode. I think we've just begun that smash-up process. I think we're looking now for other ways that we can embed new technologies in the transactional activity that takes place on a telepsychiatry network. And then finally, I want to add to the comment about expanding your staff. So the behavioral health urgent care model is a nurse practitioner on the front end of it. And the nurse practitioner obviously has a fairly wide span of control in today's world, and are much more easy to educate and to get out into the workforce than a 7-year journey for psychiatrists. So this will allow us to have a nurse practitioner do the initial diagnosis, but call in a child, adolescent, adult, dual, and geri psychiatrist available to them, beck and call, ready to help them at any time that the organization has the urgent care centers open. That changes the dynamic. Try to get an appointment with a specialty psychiatrist today. You're waiting 90 days. Your disease is either floored or you forgot about it.
So, Sandra,
I want to just make one more comment with regard to telemedicine in particular. Regardless of the setting, I think most of us have experienced, unfortunately, going to the doctor's office and having the doctor not really look at us, but look at the computer screen as they're documenting what we're saying. They're talking to us while they're documenting in their computer screen. So anything that we can do to even if they're looking at the computer screen and it looks like they're looking at me through a telemedicine, that's going to make me feel a little bit better. So I think that that there are benefits to telemedicine that we haven't really seen yet. But again, if there's anything that we can do that does create a interaction that isn't occurring now in a good way, I think that it's a better.
I think the next step is us sorting out the work, much like what happens in a court system. You don't have the judge taking verbatim what's going on in a court hearing. You have a stenographer doing that. I believe that it's our obligation to triage the labor assignments in an episode so that we have scribes working. And there are many emergency departments and other groups who use scribes today. I think that's a better way to get more out of the talent that we have to pay very significant amounts for. So we don't do that. We like the doctor to do the whole episode, and I think it's a waste of time.
And I'm going to make one more comment along that line. And I think
can't you wait until we join together
in
the same
it's
health system?
It's going to be so much fun.
We're going to have these arguments every day.
It's all good, though. It's all good. So, and I'll give a shout out to New Jersey Institute for Innovation as well. I think voice is a great example. The innovations in voice, and just recently they hosted a big conference on voice technology, and Amazon was there. And not that I'm plugging plugging Amazon, just some recent efforts there have indicated just what they are doing with voice. Google is doing the same thing. Voice is a great example of how you can take that labor side of things and use innovative technology to automate a process that is right now very manually intense too. So I think that as we continue to look at how we can make things better, that technology, just the innovation in technology is going to drive the ability for us to make care much more efficient and cost effective over time, and actually much more personalized as well.
So at this point, I kind of want to pivot our conversation a little bit. We're talking a lot about the hows. How are we going to do it? And how are we going to use this piece of technology? I want to kind of move into the why. Why are we making all these investments? And we've got a lot of folks here with a lot of brain power, and they're touching individuals in different ways. So one of the whys for me is, why do we do it? Because we want to improve health overall. And we have folks here that are representing a whole bunch of different interests. And it's from, I would say, physical health to behavioral mental health to, how do people, connect in through technology? What do the payment systems look like? And then ultimately on this big end, you've got, John representing the, how do we connect this all together in the sky somewhere so that patients, consumers, family members can connect more easily? So I want to, I think, start with this piece. And first, because we have both behavioral and physical health here, and gosh, how many folks in the room are thinking these are two separate entities and two separate things in its entirety? Yeah, I was kind of thinking the same too. Who believes, though, that if you go for a physician's visit, you should have a screen for your behavioral health, and if you're in behavioral health, they should take your weight and your temperature and your blood pressure? I've seen a lot of heads shaking yes. I know that that's one of the focuses, that we're trying to break down some barriers, and we're talking about how do we integrate. So I actually want to, I think, start off with Bryan on this one, because you've got the Don and Sandra show going on here, because Carrier and Hackensack, they better be on the same page. But Bryan, you're kind of a little bit of an
I would love to talk about this. Healthcare costs, I'll give you an example. I go back to addiction because that's where my specialty lies. 70% of the people in America who qualify as addicts are employed. They're in all of our workplaces, right? The addict himself uses 7 times the health care as a non-addict. Their spouse, this is the real shocker, uses 3 times because they're worried sick. So the idea is, how do you interrupt this pattern earlier in the process before they hit bottom, before they start becoming a detriment, they start ruining your brand, workplace violence, sexual harassment, all the untoward problems that arise from somebody who's not thinking clearly and has a behavioral problem or an addiction problem. Part of what we're doing here is we're giving, it's a self-assessment. Basically, all assessments are self-assessments. When you come into our treatment facility, they ask you questions and you answer them. Either you're going to answer them appropriately. Of course, the person doing the interviewing has a skill at drawing out truth. But for our purposes, we give industries an opportunity to screen all their people before they even get there, before they hit that point. And again, you start recognizing yourself in some of these behaviors. The idea is to interrupt these patterns before it gets there. Then there's a solution here that is literally pennies a day. I'm a businessman. I'm looking for the biggest return on my investment. If I have an employee who needs hospitalization, who needs detox, this is not that. But this is something that can be given to a spouse, could be given to, there's a gamification. The whole idea is to make people want to use it. This is not an app. This is a whole system. This is the most comprehensive program for recovery from addiction that's available anywhere. And I'll say that because I'm in the business. I own a treatment center. I know it's available. It is not a replacement for treatment, but it is a 24-hour tool. It's a recovery tool chest. It's a suite. And it uses everything from technology, from GPS locators to every 12-step meeting within 20 miles of where you're standing, wherever they're at, to ways of interrupting negative thinking patterns, to questions on anything recovery. This is the Google of recovery programs. And by embracing technology, we've been able to take the cost and drag it into the gutter, make it so cheap. was what's the barriers to people getting help? Right now, only 4% of the people needing treatment for addiction, even though it's the #1 problem, health issue in this country, only 4% are getting any treatment because either they don't have health care, or they have high deductibles, or they can't take time away from family and personal obligations. There's several different reasons why this happens. So this is a way for somebody to stick their toe in the water and hopefully interrupt that pattern before it gets too deep. And if they do wind up in treatment, it's also a way to follow up them in their aftercare program so that they have support when they leave. Typically what happens is they leave a treatment center, and a great majority of them, unfortunately, do not continue with their psychiatrist, their counselor, or their 12-step program, and relapse occurs. So this is a way to get people in the fold, keep them moving forward, and embracing technology and lowering the cost for industry, for the person, for the treatment facility, and getting better results.
So I'm going to pop over to John really quickly first. John, you know, we've heard about some of the challenges of actually sharing data between physical and behavioral. Can you tell us what are some of the technology approaches, solution? What's the hope for the immediate future in this area?
It's going to be a challenge for the immediate future. One of the things we do see when you talk about the larger, the Cerners, the Epics out there, they don't necessarily, when they look at a medical record, they're not classifying what's protected data, what's free to share. So we see there's a lot of organization. Now, again, I've worked in ambulatory, I've worked in acute care, I've worked on the payer side, so I've seen it across all the areas. They're very reluctant to share that behavioral health. As soon as it smells of behavioral or substance abuse, it's just it's not shared. And there's no easy way within the EMRs to classify that. I did do a project with Cerner a couple of years ago where we were trying to do just that, be able to mark records that had behavioral health data so they could be shared appropriately. But I don't think that there's going to be a quick fix for that. What it is going to be is that openness. There is regulation that says you can share it, but organizations are still very reluctant to take that risk to share the data across it. One of the things that I think would help is trying to develop a statewide consent model where you talk about the phones. You have the one thing that we really haven't talked here about today is a consumer. They're ultimately in charge. It's their data. It's not our data. It's not a hospital's data. It's their data. You had mentioned Seema Verma earlier, Center for Medicaid and Medicare Services. One of the things they're pushing is their Blue Button app, which basically allows any Medicare recipient to log into an application and get 3 years of their own data. And then they can do whatever they want with it, basically. And I think that's what we need to. That's really what's going to move the needle, is you put the hand into the consumers. You've seen Apple, you've seen Google, you've seen Amazon make announcements of moving towards action in healthcare. You really, until we put the consumer in the driver's seat of their own data and them able to move it, it really is going to be a challenge to get behavioral health and substance abuse data moving across the continuum.
And to that point, John, I mean, consumers really want the three things. You know about AAA in the auto care industry. The AAA for me is accountability, accessibility, and affordability. And that's what consumers ultimately want. And when I talk to our clients around technological capabilities, it has to be a part of one of those buckets or multiple buckets.
So then we're going to come, and I'm going to actually try and wrap up with Don and Sandra, because we're talking about a lot of, I want to say, concepts, and they're sort of high-level ones, around IT, around data. They're probably going to jump there, but I'm also going to ask, can you just give maybe a case study or an example of where we're dealing with an integrated behavioral and physical health issue, and what have been the challenges in the past, and maybe how technology is helping you actually resolve those?
Let me comment on what I like smash-ups. I like to take two things and pull them together that normally wouldn't be together. So the advent of neural nets in the neurosciences area has allowed us to look at the brain in an unprecedented way. We can watch the activity that's taking place as a result of different conditions and or in different circumstances. What we found is that the hypothalamus actually shrinks during a drug and alcohol episode. It makes sense. The drugs take over the function of sleep, endorphin production, concentration from the body, and actually seed it to an outside substance. And then during that time, the hypothalamus loses its functionality. Today, we take the substances out of you and don't do anything to the hypothalamus. We wouldn't do that with a broken leg. We do PT. AA, I actually believe, is an inadvertent effort to do PT because it gives you structure of 90 minutes and 90 days to actually have your hypothalamus recover. That hypothalamus, twice a day, 45 minutes each time, we stimulate it with a TENS unit, similar to what you've used transcutaneous electrical stimulation on a muscle. We get that full functionality back of the hypothalamus in 6 to 8 days, and then send you out fully equipped so you're not put in a situation of a relapse constantly. So and our patients, we've actually just completed the University of Pennsylvania study on this. We'll have the data published this fall. We're going to go right into a University of Arizona to look at the long-term impact of this technology. Those kinds of things wouldn't happen if we weren't working with across the aisle between behavioral health and acute care.
Just one additional example, one of the things, and I'll start with an oncology-based example first, where we're actually, I'll use Smash Up. I like that. See, we're working together already. So
we may be doing a lot of that in the future.
Where we're actually bridging financial and clinical information to really break down as cleanly as we possibly can very unique sets of patient populations and aggregate them so they're as like as we possibly can, and then begin to understand their journey, if you will, through different kinds of treatments based on very specific outcomes and measure those outcomes in the treatments. And usually what we've been able to do is have the physicians and the clinicians identify very specifically what should be the core effort in that core journey for that patient for the next 90 to 120 days to a year, if you will, for oncology, for this particular patient population in oncology. And they outline it, and then we measure against that both financially and clinically as to whether or not they've actually got that. And the variation is pretty astounding. And, you know, we spend $3 trillion in this country on healthcare, and about $1 trillion of that is identified as waste. And that waste is really just variation. And it's interesting because even in the breast, we've done this in breast cancer, is about very similar. About a third of the population has a lot of variation with no difference in outcomes. So we spend a lot, and the physicians who develop the protocols actually don't follow those protocols. And it's just a number of reasons why. And there's no rhyme or reason other than the systems don't support them and don't make it easy. So having said that, we're actually in the process of doing the very similar effort, even down to the genetic level as much as possible, for depression, different types of depression on behavioral health side, and trying to manage that both on an inpatient side, but also more importantly for us, on a private practice side for our primary care physicians, because that's where most of the depression is managed. And it's all over the place. And so our behavioral health teams are going to be working on doing that and leveraging not only the clinical information but the financial information with targeted outcomes and measuring those outcomes. So it'll be interesting to see how that comes to bear. So it'll be a case example that we can share, but we don't have the results of that right now. But it is a great way to begin to say data can come together to support both clinical and financial gains in a good way for patients if we can just figure out how to make sure to bring it together in a way that focuses in on clinical outcome.
So, pretty fascinating, robust conversation, a few slightly different perspectives, but I think what we're hearing is a common theme. One, we've got a lot of data out there. I'm hearing data fatigue starting to be an underlying message here. We've got to figure out what we're doing with the data. We've got to start creating better pictures or stories about what's happening among the patient population and among the healthy population. I'm hearing as well. When we hear things looking for fatigue, looking for depression, it's those precursors, those things that are going to lead to either chronic disease or behavioral health issues. It's figuring out cost and how to get really transparent, not just about what the charge is, but what is the cost. And, I've heard the references to Amazon, and we're seeing what's taking place in there. And I will say one of the challenges I'm coming to appreciate as everybody's trying to figure this out is that it's about scale, and it's about who's the staff that's on site at any given time and what staff is available. So we've heard all these different themes. And with that, what I'd like to do is open it up for some Q&A. So if anybody has any questions, feel free to fire away. If you'd like to make them really difficult, we appreciate it.
Thank you very much. Bryan, thanks for the book.
Oh, you're welcome.
He's giving autographs later.
Excellent, excellent. I wanted to ask Don to tell us the other three pieces to the compassion index.
You mean the
Eye contact is one.
So you mean what the top transactions? Eye contact, which kind of surprised me. It is verbal language that's used. So we have a variety of words that we've identified that are used in the transactions that take place. It's proximity to the individual. These are all the things that you could take this in your hand and figure out what's not happening with your communication, and you would be on target with what we've identified through our effort to create a compassionate care experience. So, so number 4, give me 1 second, I will remember number 4. Got it. Okay, so in addition to proximity, it is touch. And physical touch, and that's interesting in a psychiatric facility. It's interesting anywhere, in any facility today. I can tell you that we haven't gone down the touch lane yet, because we haven't figured out how to do that without reaction, without all different kinds of things. So we've stopped at proximity.
Hi, my name is Amanda. And I wanted to ask you a little bit more about how you think technology is evolving in regards to helping with making healthcare a little bit more accessible and affordable to people. And in regards to, is that making more websites, and you said regarding more transparency, or is it more telecommuting to keep the costs down? Because I know that even when it comes to like healthcare costs in the United States, it's almost 3 to 4 times more expensive than a lot of other countries, even right across the sea.
So that's a really good question. I'm going to ask a couple of people to do a few takes at it, and then also acknowledge that when we talk about healthcare costs, that bundled into it here in the U.S. is a lot of R&D that's not shared, I'd say, probably equally internationally. So a lot gets embedded within costs here. And we see some of that. So, Sandra, you maybe want to talk a little bit to begin with, because you've been very active.
Yeah, one of the things, and she doesn't mean just this panel discussion either. So, but one of the things that's very unique is that there's a new platform that came out. So I'm sure everybody's heard of Priceline, where you're matching supply and demand, basically. I want a room, and I know there's a room available. I bid on that room, and I can get it at a certain price. There's a new platform that's come out of Manhattan that is actually trying to do that as well for people who are looking for certain kinds of office visits for a certain price, and they're looking to be able to do that for convenience. So you can literally bid on certain kinds of services, and we'll be bringing that into the state of New Jersey within the next month, so that people can actually have some access. And so it hits one on convenience, it'll hit on price transparency, and it'll actually hit on the ability of providers to actually take cash, which seems to be a challenge in a lot of primary care practices. We don't know how to take cash. We know how to process claims, but we don't know how to take cash. That's a sad thing. But anyway, having said that, so that's a good example. So you're going to see a lot more of platforms that match supply and demand, because it's not an easy thing. ZocDoc is an example. Has anybody heard of ZocDoc or used ZocDoc, where you go online and you try and get an appointment? It's not as easy to do that in some respects, because the doctor tells you when they're available. This way you tell the doctor when you're available, and they can tell you if they want to take your case or not, and they can counterbid and all that kind of good stuff. So that's a good example of one, and it's all mobile-based. Other things that are coming to bear is really just the telemonitoring and telemedicine that I want to be able to get a telemedicine visit right now. I can literally go on my phone and do it. That's available for the most part locally. So there are a lot of those kinds of things out there. So I'm sure there are others that are able to talk about those. But I think that what you're going to see is more and more capabilities that are going to be extremely easy access on your phone. where people are really trying to drive low-cost services because of the high deductible plans, where you can use your HSA cards. Most of them are debit cards anyway, where you can actually get the best benefit for that dollar as much as possible. We're seeing in Manhattan that people are getting colonoscopies. Sorry, they're bidding on colonoscopies. For probably a fraction of what you would normally see them being reimbursed for.
They also throw in proctology exams with that.
Exactly.
Both simultaneously.
Yeah, just do them all at once. Sorry, I put my hands under my helmet. But it's because it's about convenience and trying to create some ease of access.
So I think it's going to be a little bit different nuances that instead of you looking for us, we're going to be looking for you.
Yeah.
And so we're working on a project with MIT and with Princeton now that a wearable device goes on. It transmits on a second-by-second basis your vitals, 6 vitals, to us. We create a personal profile for you of your vitals from the point that you're psychotic and entering the hospital to the point that you're recovered. We're looking now at the deviation from your recovery baseline of vitals that will have predictive value for a potential relapse. When we see that, when we start figuring out each person would be individual in that regard, we're going to call you back in and get you settled on your medication or whatever other strategy we've used to treat you before you relapse. Relapse, an average psychiatric patient takes 17 years off of their life, and it's 14 of those years have been isolated to loneliness, profound loneliness. First time you have a psychiatric episode, you lose some friends. Second time, you lose your job. Third time, you lose your family. Fourth time, we're looking for a boarding home for you. That's the life of a profoundly psychotic individual or schizophrenic person who has those. So we're going to be taking a more proactive approach, I believe, and then getting you in advance of that psychiatric relapse.
And just 2 other points. So everything that you talked about, Sandra, are very key. All right, around the price line, the bidding. The other aspects are it doesn't all have to be virtual, right? Uber Rides has been really successful for a lot of health systems, reducing no-shows, getting patients on time to appointments as well as schedules within the hospital. So doesn't have to be all virtual. Although when we talk about email communications and chats, 50% of consumers are okay with sending information digitally around communication. So you're going to start to see a little bit of a new staffing model too around chat centers rather than call centers, right? Building up the nurses, the physicians, as well as those folk who can respond to those emails on a timely basis are definitely going to be more prevalent in the future.
I think Gil did really hit on something there with talking about the Uber is, and actually Bryan mentioned it earlier too also, it's not just about the episode of care. What happens when you get out of that? What are the social determinants? If you're taking a person who's leaving a hospital, an inpatient visit, and going to a home where they don't have the transportation or the food or the heat, you're not setting them up for success. So that's one of the pieces I think, or they'll also start to come in. And you talk about all these wearables, the mobile devices. They're going to start to bring that data in and be able to use it. And that's something I think we've neglected in healthcare, that we don't look at that aspect of it. And that's really something that's got to change and move forward.
So, I think that's a really good point that you're raising is that, one of the things that everybody, I would say about 75% of this room raised their hand and said yes to a Fitbit or some sort of a wearable device. What's really interesting is that you've made the decision that's how you want to engage and manage your health. And what's really interesting is that that's not connected to your EHR. It's not connected to alerts from a behavioral health or a physical health perspective. And when we think about this, take something as simple as your Fitbit, which is showing steps, and say that you used to do 5,000 steps average a day, and it all of a sudden goes down to 700 to 1,200. Is that telling you from a behavioral health perspective a story? Is it telling you from a physical health perspective a little bit of story? And so, that's part of it when we say we need to begin engaging differently with consumers. Because a lot of it has been what we think consumers need, not saying, consumers, how do you want to interact with us? How are you already interacting? And what can we do to support it so that, this next generation stays healthy longer, that they don't suffer from multiple chronic diseases? And I know Sandra can talk about this, and I know Don can because they've been in the room when I've been on the rant too. But, we take a look at what are the leading causes of death in this state, and they continue to be chronic disease. And that's why there's been so many efforts around health IT. And that's why you hear John talk about episodes of care. You hear Gillie talking about what do you need to do from the financial perspective to make sense around it. So, we've got that. Do we have other questions in the room?
Hi, my name is Steve Smith. I work for BDO. I lead life sciences and technology practice there. What I interested in March, I was involved in an automobile accident out of state at work, and I've gotten to see a lot more healthcare people than I had before in my life. And every one of my appointments was scheduled by the workers' comp people. And every time I went to the doctor, went to the local hospital, Riverview, one of yours, went to an orthopedic doctor, went to physical therapy, went to chiropractic care, went to MRI, facilities. Every one, I had to fill out an 8-page front and back piece of paper about all this stuff. They knew exactly who I was. My appointment was scheduled. They knew exactly why I was there. And I filled out all these papers, and including at many of the facilities, my name, social security number, address, all of these physical pieces of paper that no one could tell me what happens to them after I hand them back across the counter and go in. It just seems like and usually I've always just seen my primary care doctor, so I never experienced this before, but now I have a whole new range of people helping me. But this whole intake process, A, is rife for terrible privacy problems, but B, just waste and the opportunity to get it all wrong. It seems like if I look at technology, that would be the easy, that's the swipe the card, you know who I am, what am I here for?
So I really appreciate that comment, and I think everybody sitting up here does, because it is one of the great frustrations. And I'm going to actually ask John if you would jump in and talk a little bit more about why it's so important to have this master patient index. And it will also get to the answer of why you suffer the way you do today with filling out and refilling out the same sort of intake information.
I've had the same issue. Is you go to a different doctor or whatever, and you have to you start from scratch if they don't know you. And that really is the fundamental problem, is if they can't identify you, no provider wants to accept your data from someone else unless they know it's yours. Again, this goes back to my earlier comment about you have to put it in the consumer's hand. And then it's their information. If they validate it, who knows better if this is my medical history than me? We're far away from that until we can identify people across the entire continuum and get that everyone is participating in that. It is hard to identify you and move that record. And it is a challenge, and it is something that we should easily be able to do. And as you said, you put your social security number in. What happens to it? Do they actually enter that in, or do they just put it in a file somewhere? I think it's probably a lot of places, especially primary care physicians, it never really does get entered. It gets put into your file. They put some basic information, and they never get back to it. So it really is, how do we get the providers to put that appropriate demographic information into their EHR so that it can be then shared consistently, and that it's in the right format so that it's not a challenge to share. There's very simple demographics: first name, last name, date of birth, address, cell phone number, and email. Those are actually probably more appropriate these days. Your cell phone number and your email last longer than a lot of people's addresses. So that's a great way of identifying people. So we need to come up with those standards and get everyone to really agree with it. And we definitely can't do it at a national level. At least maybe in New Jersey we can get it right here.
And look at all the downstream effects of that too, right? Clinically speaking, maybe you received the EKG at this other facility, and the information wasn't shared. Now the other hospital wants another EKG. Now, I just had one a few months ago or a few weeks ago. How does it differ? So we start talking again about cost and the clinical implications of that. And again, that's just a big waste of healthcare.
It is, I think, sometimes a waste of healthcare. But I think you'll also hear a warning from somebody like Sandra that says, let's be careful not to jump so heavily on the efficiency train that we forget what is the good clinical protocol as well. So there's a couple of things going on, right, Sandra?
Yeah, and I would also just highlight that is a couple of things that immediately come to mind. One is that even if that EKG had been done at another location, I don't know if it was acted on. That's the other component. So if it wasn't acted on, has there been a change? So, there's a couple of, clinical protocols that would have to be followed. So there are some protocol-driven issues there and some, medical liability issues that come into play. And I would say that workers' comp is a good example of where there's a lot more complication to the requirements for data and data collection on the claims side. So some of that is actually driven by the workers' comp. So it's a complex issue. Now, that's not to say that that front-end piece of registering and collecting basic information should be as frictionless as possible. We have to figure that out. There's no reason we can't, as an industry, figure out how to make it frictionless for patients. But I will say it's not an easy lift. But you're absolutely right. We got to figure it. It is ripe for innovation, and that's exactly what some of the Googles and the Amazons are going after, quite frankly. That's because it is data that can be automated. So why can't we just automate it? That's their perspective.
Fascinating discussion. My name is Himanshu, and just one thing I wanted to touch upon that was mentioned was physician burnout. So, a quick comment and a question on that. The comment is, again, I'm no longer a practicing physician, but, was there, and I'm a spouse to a practicing physician, so, I have this huge network of physicians that I'm very close with, and I see that, physician burnout is real, it's happening, and, it's really affecting, it's affecting our providers, it's affecting our patients, the reason, those people, and all of us kind of came to healthcare. So at least, nothing else I wanted to echo, and just say it out loud, this is something that's really critical and needs to be addressed. And the question on that behalf is, what can, these people do to kind of, reach the influencers, which is most of you guys here, as to kind of, connect with, the policies and, kind of just share their voice as to, what's kind of happening to them, how much, the workload is affected, and, how much of, as you're saying, they're kind of looking at their computers, and there's actually a survey that says 70% of these physicians do not want to do that. They want to interact with the physicians. So, the question is really, how do we get that word across from those providers to, influencers such as yourselves?
I think that's a really good question, and I'll actually say that first. I think that from a national perspective, you have an increasing awareness. I know that recently Secretary Seema had done a couple of tours with hospitals, and one hospital in another state brought her to a room, and it was filled with individuals whose sole job was to enter information into the EHRs or to validate the information with the chart for, so data entry validation. So, think about what that does in terms of even being a cost driver for a system. And now I'm going to actually ask our panel to talk a little bit about, you have this recognition now from CMS, and they have made a commitment, by the way, to reduce the regulatory burden to try and address it. But I'm sure that they all have different things while they're waiting for federal action, which a lot of data pieces are federally mandated. So while they await it, what did they do at the local level to try and abate some of that burnout or fatigue?
Well, one of the things that drew me to Meridian Hackensack was the new medical school and we have a psychiatric residency program, and both of those rotations will be coming through Carrier. So it gives us an opportunity to actually set you off on the right foot. And frankly, depending on your capabilities, to weed you out and allow you to make a decision quickly about whether medicine is right for you and whether you can sustain yourself over a period of time. I think one of the major areas that I think we can help our physicians is expand scope of practice. So we have a post residency fellowship now with St. Joe's Hospital, where we're rotating their emergency department doctors through Carrier for 6 months. And so that they actually go through all of our different components of psychiatric care. When they go back, they're in the ED and can pick up psychiatric activities quickly, which frankly, if that's the motive, helping, gives you a broader range of people that you can help without the frustration of having to wait for a psychiatrist to come 24 hours later to see your patient. So I think scope of practice actually is an area that will, if it's restructured properly, provide us a palliative for the burnout that our doctors are feeling because of the extra technology requirements.
Yeah, one of the things that we're asking people to do, particularly on the medical staff side, is we're literally going around and saying, what are your pain points? How can we help you? How can we make it easier for you to practice medicine? Because as we're trying to make it frictionless for consumers, we also want to make it as frictionless as possible for the practitioners to take care of the patients. So that's one of the things that I think is mission critical, is to better understand what the pain points are, because our role as leaders within the network is to really, particularly for me on the innovation side, is to understand those pain points. Then I'm looking for what are some of those innovative solutions that we can employ that aren't going to add extra work, but can actually resolve a problem that people are having and make it easier for them to take care of the patient. So I think constantly just banging the drum in a good way. And for us, the other thing is we've got to engage our medical staffs better in problem solving, problem identification, but also problem solving, and making sure that when we're solving the problem, we're truly solving the problem.
I'd like to say something. We have a first responder program, and almost exclusively every one of these folks who comes in, our law enforcement, our firemen, our department, they all have PTSD. Who sees more trauma than a physician? It's almost like doctor heal thyself. We offer EMDR, we do hypnosis, there's mindfulness, there's ways that, in the busy world, what I've seen just in our own treatment facility is that the doctors and the clinicians are the last person to look in the mirror and say, hey, look, I've got to take care of myself first. And I think that's something industry-wide, because from the second they get out of school and they're doing their residency, they're taught to push, and it's not healthy, and it doesn't help the end user, the patient either. So I honestly believe when I look in the mirror myself in the morning, if there's a problem, I'm looking at the problem, and that means I have to take some of my own advice and take some different action. So
just, if I could just do the one thing I want to add on that is there is also the technology aspect of when you talk about burnout is we've talked a lot about data, not information. One of the challenges that we see is when someone's admitted, discharged, or transferred, ADT, anyone who's in healthcare in a hospital knows an ADT message, is a lot of services will notify you with those messages. Unfortunately, 600,000 of them come out a week from an average hospital. So what we need to do is filter out that you get the appropriate message so they're actionable. When one of your patients, one of your high utilizers, one of your chronic care patients is seen, that we send you that information in a timely manner that's actionable, that you can use. So there are pieces of technology can be leveraged to do that, and then other things such as smart alerts. When you have a specific patient, New Jersey Hospital Association is working with an organization for opioid alerting to help connect to the PMP. So you take something and you take information that is being directed from an individual and you can return to a clinician information that's pertinent to that patient's care episode, you start to help at least move that needle a little bit. So technology can be used. It's obviously not going to be an overall solution, but it's a little piece in the puzzle.
Good morning. I want to thank the panel for their information shared this morning. My name is Kurt Bishop. I'm with a company called General Devices, a medtech developer here in northern New Jersey. So certainly you're believers in technology, and I would bet majority of the audience here is as well. I think that in some ways the technology is the easier part of the solution, and that the more difficult part is the people and the implementation side of things. So I think we get it, and our primary solutions address hospital needs. But in the hospital environment, it's the proverbial frazzled customer that's busy on their day-to-day activities, and it tends to be siloed in departments, cardiology, neurology. And some of the solutions cross those departments. Do you have any suggestions on how to get those messages across? Certainly starting with a good positive value proposition. And an innovation department is perhaps an avenue. But getting the attention of a hospital when you have solutions that on the technology side that are probably very beneficial, but overcoming that people barrier to implementation?
So I always, when I'm confronted with those kinds of issues, think about where decisions start, and they start with our board. And so in the past several decades, I've asked our, now that I'm a carrier, I've asked the carrier board, and they've been engaging for the last couple of years in this, is to conduct focus groups with patients, board members. Teach them how to do it, teach them how to interact with patients, teach them how to get information from patients, and then teach them how to engage that information in solutioning issues along with the administration. So it gets a better partnership out of it. And then we apply what's called design thinking. So we use the processes that are in all the transactions that we do and design them around patient desires, much like our compassionate care index, using that information to redesign care. I think that makes a difference for everybody. And frankly, as a CEO, I'm caught in the middle oftentimes between how much the board's willing to give me to solve problems or prove that I go in the hole for to solve a problem versus what I need to make in order to ensure our financial success. I found our boards to be more accommodating to us in decision making to fund the right things. And that for me has made a world of difference. And I think it's made a world of difference for our staff to understand that the people that are responsible ultimately for the operations of the organization are more in touch with what is going on with staff. By the way, they also engage in interviewing our doctors on a regular basis, so that they're doing focus groups with our doctors.
Yeah, and I think the operational pain points, to your point, Sandra, are key, and it provides the ROI for technology often. So sometimes we flip the discussion. We go in with the technology focus, but then we start talking more around the operational ineffectiveness of the organization that needs technology. So there's another component from an ROI perspective.
Yeah, I think one of the things that we do, we actually have a investment arm as well. So one of the first things we do is ask you, what's the problem you're trying to solve? And I think going back to that point is that every organization is different as to what's the best approach to getting in and who's the right person to talk to. But they all have problems. And I think if you start out with what's the problem you're trying to solve and really trying to understand who's trying to deal with that problem the most in any organization, that helps guide who to start with. And you're right, people are the biggest challenge when it comes to trying to institute anything new, much less whether it's a new technology or medical device. But I would always go back to what's the problem you're trying to solve, and then here's how my device or my technology actually resolves that problem, and how big that problem is, obviously, for that organization.
Okay, we have time for one more question.
Good morning. Thank you for being here. It's such an excellent panel. And I'm going to read from my phone to make sure I don't miss anything. It's critical to utilize innovation to help solve problems in healthcare. We have a problem with addiction, a problem with high rate of preterm births and infant mortality, premature babies that cost the HMOs and the state hundreds of millions. New Jersey has a high rate of autism in the state. Can the hospitals and the HMOs utilize data to identify pregnant women in the early stage of pregnancy, like the first and second term, as opposed to the third trimester, to increase the odds of full-term healthy babies to save lives and save hundreds of millions to the carriers and the state?
So short answer is yes, we can. I think that the issue isn't if we can, because we can absolutely. It goes back to the how. How can we do it, and what are some of the ways that we can implement? I will tell you, the implementation is the critical issue, regardless of anything that we've all talked about. And I think there are a couple of things that immediately come to mind, but something of that magnitude is going to take a lot of strategic partnerships and really getting a lot of buy-in by private practitioners, state agencies, et cetera. But there is no reason that we can't use technology to help, even for patients to self-identify as well at when they're in early stage of pregnancy, and begin to monitor in such a way that we can also provide them with the tools to identify when they're at risk for different kinds of situations. So I think that there's definitely a way that we can leverage technology. It's about the how. how we can do it and implement it in a way that results in a positive outcome for all.
And I will say that that's something that we, as a hospital association, together with all of our members, have committed to. We've been working on, improving maternal outcomes, improving infant outcomes. We have one of 13 nationwide funded by CDC perinatal quality collaboratives. And I have to say, when all of your members step up and say, this is important, that's a big piece of it, the clinical side. At the same time, we recognize that this is something that's also a cultural side. How do we make sure that moms and their families and the communities around them know what the warning signs are, know what the risks are, so that early on in a pregnancy, if they see something, they know how to engage or they know when to engage. So we've got, I think a lot of work to do with both sides, but we're really fortunate that we have, a lot of stakeholders at the table. We have the State Department of Health, and the Commissioner has been very helpful to us. We have within NJHA itself, all of our members. We've been working with the obstetricians and the gynecologists. We've been working with the Academy of Pediatrics. So, this is the important piece. You've got to knit it together. And I think, Sandra, you hit it, head on. This is not something that happens alone. Everyone needs to come together. And I think that's the theme today, really. What you've heard is we've dove in and out. We've had some policy and we've had some technology. We've had some policy and we've had some operations. And then we've had technology. And what you're seeing is, I think, this evolution or this shift in our system where we've said, you know what, we want to first make sure that those that suffer from chronic conditions, whether the chronic condition is a behavioral health condition or whether the chronic condition is a physical health condition, we want to figure out how to identify and better manage and produce the right outcomes. And now we also want to turn our focus into the types of technologies and devices and apps that will support health and wellness overall. And we want to make sure that we're not just looking at data points individually, but that we're bringing it together from a population perspective so that we start to drive improvements in population health. So I want to thank all of our panelists today for the phenomenal job. And what I'd like to do right now is turn things over to Howard, who's going to wrap up for us.
I think that we want to give a round of applause to our moderator, Cathy Bennett. We're very privileged to have had her today, as the rest of the panel. Thank you all so much. Coverage of today's event will appear this afternoon on NJBIZ.com. It will also appear in our weekly print edition. If you're not familiar with our print edition, we can sign you up for a trial subscription. Just see the folks at the desk on the way out, and they'll be happy to sign you up. I want to make an announcement. Next month, we were going to do a panel on manufacturing, but we have decided to change the topic and do a second panel this year on cannabis. We expect there to be some activity in Trenton within the next month, and so we figure it's a real timely discussion to have. September the 18th, right here at the Imperia. I hope you'll all come and partake in that discussion. With that, I want to wish you all a great day. Thank you very much for coming today. Take care.